Okay, so this is for those of you now watching the recording. The video cut out on slide 6, so we're going to pick up with 6 and continue on our way. And then if everybody but me could just mute themselves, that would be great.
On slide 5, you were talking about what we need to know in the table, and I think you cut out like right before you told us what we need to know.
Oh, okay. I'll start with slide 5. Thank you for letting me know. Okay, so this table I included, and I guess what I wanted to point out or say about it is that typically, I know I'll oftentimes make the disclaimer, oh, don't worry, when it comes to anatomy or histology, you'll be tested over that in lab, not in lecture. And that's not necessarily the case with this material. And, I always hammer home the concept that structure determines function. And so I do think it's really important with this material to have an appreciation for the changes that occur histologically speaking as we work our way through the respiratory system, starting even through when we look at the upper versus the lower respiratory tract and we compare the epithelial tissue and the amount of smooth muscle and cartilage, et cetera, that we have in the upper airways versus the lower airways. Because there's a reason for that, right? There's a reason why our alveoli don't have cartilage, don't have smooth muscle, and are made up only of simple squamous epithelial tissue. And that's because, again, structure determines function, and the function of the alveoli is gas exchange. So you want as thin a tissue as possible, making up those structures. So this is just kind of a summary table that I would refer back to often, just to help remind yourself about what we find histologically speaking when we talk about structures of the upper and lower respiratory tract. And just please, again, everybody look to make sure you're muted. Okay, thank you. Okay, so as we make our way down the respiratory tract, one thing that is very apparent is that there is a change in epithelial tissue, right? Most of the all of the structures in the upper respiratory tract and many of the structures in the lower respiratory tract, in fact, are lined with pseudostratified columnar epithelial tissue. And this tissue, as we talked about in 227, is ciliated, right? And something you'll notice is that there's tissue types that we're going to talk about that are not often ciliated, that are ciliated in the respiratory tract. Anyway, more on that to come in just a second. But structures that are lined with pseudostratified columnar epithelial tissue that's ciliated include, of course, the nose, the nasal cavity, the paranasal sinuses, the pharynx, the trachea, the bottom portion of the larynx, the bronchi, and then the lobar bronchi. All of those are lined with this type of tissue. And this type of tissue, some of the characteristics of it is that there are lots of goblet cells, right? Goblet cells are the cells that make mucin or mucus. And so we find a tremendous amount of mucus-producing cells in this area. So that tells you that these structures are able to produce a lot of mucus, which is important for trapping particulate matter that might be inhaled and preventing it from getting into the lungs. And that's what the cilia do for this tissue as well. They help to sweep out particulate matter and help to reduce the likelihood that particulate matter will make its way to the lungs, where it could be very damaging. Then, as we make our way lower down into the bronchial tree, or through the bronchial tree, we see that there is this transition from pseudostratified columnar to simple columnar epithelial tissue, simple but still ciliated. This is the kind of tissue that we find that lines the segmental bronchi, the smaller and other smaller bronchi, and then also the large bronchioles. And we've not gotten yet into what we're seeing as far as changes in cartilage and smooth muscle, but we will, just kind of FYI. Um, then again, continuing to work our way down, the tissue, the epithelial tissue transitions again to simple cuboidal, which is an even more delicate type of tissue. This tissue is still ciliated. This is the kind of tissue that we find that lines the terminal and respiratory bronchioles. And then and I should say, once we get into the respiratory bronchioles, um, the cilia are all but gone. Once we get into the respiratory bronchioles, that tissue is made up of simple cuboidal epithelial tissue that's on its still transitioning to the most delicate kind of tissue that we find in the respiratory system and in the body, which is simple squamous. And simple squamous epithelial tissue is the kind of tissue that makes up the alveolar ducts and the alveoli, and it is perfectly suited for gas exchange, which is what those structures are involved in, the function that those structures are involved in. Okay, um, and I already brought up goblet cells, right? But I just want to mention again the importance of goblet cells when it comes to the respiratory system. So goblet cells secrete mucin, and then mucin gets hydrated to mucus. And mucus is there to help trap dust and particulate matter and things that would otherwise be damaging to the lungs from getting there. We produce about 1 to 7 tablespoons a day. And within those mucousy secretions, um, we find also important antimicrobial types of substances, and those include, immunoglobulin, IgA. So we talked about IgA as being what we call the secretory immunoglobulin, right? It's kind of antibody that you find in secretions. So as part of those mucus secretions, you're going to find IgA, various defensins, which are antimicrobial proteins, and also lysozyme. And so all of those are a part of your innate immune response, right? To help in general, non-antigen specific ways protect you against things that could be potentially disease causing. And then another terminology wise, another term I want to bring up is this term sputum. So sputum, that term is used clinically often. Sputum is what we call mucus that's coughed up with saliva and anything that is trapped within that mucousy saliva mixture. Sputum can be tested and is tested for the presence of specific, microbial entities, for example. If people come in and they have upper respiratory disease or upper and lower, I should just say, respiratory symptoms. Okay, so now I'm going to run through the structures of the upper respiratory tract, right? And a lot of this is going to be information you already know because we've talked about it in other contexts, or you've learned it in lab, okay? So the nose, what I want you to know about the nose, it's the first conducting structure for inhaled air, right? It's made up of cartilage, and then underneath the cartilage, dense irregular connective tissue, and then of course skin. Nostrils are also called the nares. They're made up of dense irregular connective tissue. I'm not going to ask you, FYI, the type of connective tissue that makes up the nostrils. I just put it in there because it helps to visualize, or it helps to understand what these structures do or the role that they play in the respiratory system, right? These are the first structures in which air enters, and they are there to kind of trap and humidify air. We also find hairs within the nasal cavity that help to filter out particulate matter. And then other features of the nasal cavity I want you to be familiar with. So I already mentioned that the nasal cavity is lined with olfactory epithelial tissue, and that plays an incredibly important role in both smell and then ultimately taste as well. So this olfactory epithelial tissue contains many chemoreceptors for the substances, chemicals that would be in the air that allow us, again, when those chemoreceptors bind their chemical, that's what initiates our sense of smell and or taste or both. Um, Another important feature of the nasal cavity is that it is highly vascular. So, because there are so many superficial vessels that line the nasal epithelium um, and the underlying dermis, nosebleeds, epistaxis is the technical term for that. Nosebleeds are quite common. Um, we also have, as part of the nasal cavity or associated with it, the nasolacrimal ducts. So these are the ducts that drain secretions from the eye and dump them um, into the nasal cavity so that they can ultimately be swallowed. And then as far as the functions are concerned, functions of the nasal cavity, having all of this extensive vasculature has the effect of warming and humidifying the air that we breathe. Again, all of the actual hairs in the nasal cavity, along with the fact that this area, that epithelial tissue, is lined with pseudostratified columnar ciliated epithelial tissue. Those features help to trap the particulate matter. Um, and if we do swallow them, the mucin that is being made by the goblet cells, that mucus is going to trap any particulate matter that wasn't swept away and wasn't sneezed out, and route it such that we swallow it and it ends up going down the esophagus and into the stomach, as opposed to down into the lungs. Okay, so kind of along those lines, so rhinorrhea, a runny nose, right? Runny nose is really common as far as phenomenon are concerned. We can develop a runny nose because of an increase in mucus production upon exposure to allergens or dust. We can develop a runny nose when we cry and we produce more tears, and those tears then, of course, run down through the nasolacrimal duct into the nasal passageways, and so that will increase the fluid production in that area and produce a runny nose. And also exposure to cold air, because of both water condensation and the fact that our cilia don't work as well when it's cold, that can lead to producing a runny nose as well. Okay, really quickly, the paranasal sinuses. So, and this should all be way of review from 227, right? So we have four paranasal sinuses. We have the maxillary sinus, the frontal sinus. You can see the pictures are where they're located here. And then the ethmoidal and sphenoidal sinuses. Sinuses are spaces in the skull. What they do is they act to lighten the skull. They also are important resonance chambers for sound. They help to warm and humidify the air. And then ultimately, these spaces, because of their location, if we develop an infection where we're making a lot of mucus, mucus can end up getting stuck or can accumulate in these spaces, and that can result in phenomena such as a sinus headache, right, or pain in the maxillary and the upper jaw area, because again of the pressure created when mucus builds up in that area. Oh, which nicely brings me to this slide. So sinus infections and sinus headaches. Again, if the mucus is being produced is not able to drain properly down into the pharynx and then down into the esophagus and into the stomach, that mucus can accumulate in the sinuses, and that accumulation can increase pressure and cause pain. And it also makes somebody susceptible to developing sinus infections. And that's because that mucus acts as a breeding ground for various bacteria and other germs. And that is what results in, and then oftentimes if bacteria is the causative agent, then a sinus infection has to be treated with antibiotics, oftentimes. Okay, so moving on to the pharynx. The pharynx, again, is called the throat. It is partitioned or divided into three different areas. The nasopharynx, you can see here. the oropharynx, and then the laryngopharynx is right here. Um, so we're going to go through each one of these. So the nasopharynx, I'll put my cursor on here so everybody can see it. The nasopharynx is lined by pseudostratified columnar epithelial tissue, which of course is ciliated. Some important features of the nasopharynx. When functioning correctly, this is a passageway for air, not for food, right? When we swallow, the soft palate, our soft palate elevates, which should help block food or water from going into the nasopharynx. This is not a perfect system, right? I think we've all experienced the phenomenon by which you take a sip of whatever it might be, water, and you start laughing, and then water comes out through your nose, right? And that's because this is a passageway, so water can escape and get up and go through the nose. But in general, this should be a passageway for air and not for food and not for water. Another important feature of the nasopharynx is that it connects the middle ear, connects to the middle ear through what we call the eustachian tube. So that tube is important for equalizing pressure on either side of the tympanic membrane, if you can, which is that eardrum. Also within the nasopharynx, this is where we find the pharyngeal tonsils. So the pharyngeal tonsils, you can see here, are located right here. Again, they're part of the lymphatic system. When the pharyngeal tonsils become inflamed, we call them adenoids, right? So they play an important role when we talk about tonsillectomies, or young children having their tonsils removed. We're typically referring to palatine tonsils. However, pharyngeal tonsils are removed often as well in children and in adults, because they can impair somebody's ability to breathe. So if children, for example, are snoring, that can be due to having adenoids that are impeding upon airflow, right? And again, adults can also have their pharyngeal tonsils removed if they've gotten so large that they're having a negative impact on the person's ability to breathe. Okay, the oropharynx, right here. So the oropharynx is different from the nasopharynx in that it is a passageway for both food and air. This area is lined with non-keratinized stratified squamous epithelial tissue, right? Knowing that's, if you were given that clue, that tells you that this is a passageway for not just for air, but also for food, right? Because food is abrasive. And so in order to deal with abrasion, we need stratified squamous tissue, right? Because we're talking about a wet tissue, it's going to be non-keratinized. Keratinized stratified squamous epithelial tissues would be the kind of tissues we find that make up our epidermis, for example. But again, having this kind of be the type of tissue that lines the oropharynx tells you that this is a passageway that's also a passageway for food and water, I should say. Within the oropharynx, we have the palatine tonsils and the lingual tonsils, right? The palatine tonsils are the ones that typically we think of as being, and they're not shown very well in this image right here, but I'll show you another picture here in a moment. But when we think about our tonsils being inflamed, right? If you open your mouth and look down into your throat and you can see your tonsils protruding into your throat, those are your palatine tonsils, and those are the ones that oftentimes get removed if somebody has repeated strep infections, for example. But in any case, palatine and lingual tonsils, both of those part of the lymphatic system and involved in your immune response. And then below the oropharynx, we have the laryngopharynx. So the laryngopharynx it's posterior to the larynx, right? So you can see it. Here's the larynx right here. So the laryngopharynx is posterior to it. It basically is from the level of the hyoid bone down to the esophagus, which we can see here. The laryngopharynx is a passageway for food and air, just like the oropharynx. And also, just like the oropharynx, it is lined by a non-keratinized stratified squamous epithelial tissue so that it is able to withstand the abrasion that is associated with swallowing food and water, for that matter. Or maybe not water, but other liquid beverages. Okay, so the lower respiratory tract. So again, upper respiratory tract ends with the pharynx. So now we're going to go through and we're going to talk about structures that make up the lower respiratory tract, which is going to start with the larynx and then go all the way down into the alveolar ducts and the alveoli. So the larynx. The larynx itself, the layman's term for the larynx is the voice box, right? The larynx functions as an air passageway. We're going to talk about all the different cartilages that make up the larynx here in a moment, but just suffice it to say, for the time being, that there is a lot of cartilage that makes up the larynx. So it's a patent airway. The larynx also plays a very important role. It has a structure called the epiglottis, which is made up of elastic cartilage. And that piece of elastic cartilage essentially prevents food and water from going into the trachea. So it helps to route food and water down into the esophagus and not into the trachea, and therefore helps to prevent food and water from getting into the lungs. Found within a larynx are structures that, specifically those structures are called vocal cords, which are ligaments that are responsible for sound production. So they vibrate as we exhale or expire. They vibrate and produce sound. We'll talk about more on that, and again, coming up. And then the larynx also plays an important role in helping to control pressure within the abdominal cavity. So many people are familiar with something called Valsalva, the Valsalva maneuver. And this is a maneuver in which essentially you get simultaneous closure of the laryngeal openings by the epiglottis, and you contract your muscles. So if you think about, I mean, just, because everybody gets a good laugh out of the word poop, right? So if someone bears down when they're having a bowel movement, when they're pooping, that's the Valsalva maneuver, right? It's like when you hold your brush and then you increase your abdominal pressure by pushing down. So this maneuver, it is, and or giving birth would be another example of when people are applying the Valsalva maneuver. But it increases pressure and helps to essentially facilitate those particular activities, defecation, childbirth, etc. The larynx is also involved in sneezing and coughing. So there are nerve endings that we find in the larynx. And when those nerve endings are irritated, that causes basically an explosive blast of air to come from the nose and the mouth. And that's forcibly essentially removing the air that was just recently inhaled and therefore initiated this particular reflex. So those receptors are also found in the larynx. Okay, so when we look at the anatomy of the larynx is formed by 9 pieces of cartilage, okay? I don't expect you to memorize all of the pieces of cartilage. I want you to understand the basics as I'm going to go over them. And I'm talking about for lecture. Lab is a little bit different. Lab, you need to know more of the, you need to be able to physically identify the various parts. So the cartilages that make up the larynx are held together by muscles and by ligaments, right? And we have a single piece of thyroid cartilage, a single cricoid cartilage, and a single epiglottis cartilage, which again is elastic cartilage. And then we also have paired cartilages, and the ones that are paired are the arytenoid cartilages, the corniculate, and then the cuneiform. Okay, so the thyroid cartilage. So this is showing you the anterior aspect of the larynx, right? This right here is what is called, this is made up of thyroid cartilage, right? It's made, or the laryngeal plate. Um, and what we find on this thyroid cartilage is something called the laryngeal prominence, otherwise known as the Adam's apple. The Adam's apple, or the laryngeal prominence, has a tremendous number of testosterone receptors found there. And the effect that that has is if under the influence of higher levels of testosterone, when testosterone binds to this area, it causes growth. And this is why genetic males have much more pronounced, in general, Adam's apples than genetic females, because they have higher levels of testosterone. And so it causes that Adam's apple to be much more pronounced. So that's not to say that women don't have laryngeal prominences. They do. They're just typically not quite as visually apparent. Cricoid cartilage. So the cricoid cartilage is this piece of cartilage right here. And then the epiglottis I already made mention of. So the epiglottis is made up of elastic cartilage and plays a really important role in helping to prevent food and water from going down into the trachea. So when we swallow, the epiglottis protects, essentially covers the inlet to the trachea, and prevents food and water from going down into the trachea. Oh, one other thing I still say. All of the cartilages that make up the larynx are hyaline cartilage, except for the epiglottis. The epiglottis is elastic cartilage, which, again, if you can remember the features of elastic versus hyaline cartilage, elastic cartilage is very elastic. It's very stretchy. And hyaline cartilage has kind of a mid-range flexibility. Okay, so now going on and talking about the vocal cords. So this is what you're seeing here would be if you were to look straight down, right through the larynx, this is what that would look like, right? So this is kind of looking, this is the superior viewpoint of looking straight down the larynx, right? So here you can see the thyroid cartilage, here you can see the laryngeal prominence, and then here you can see what we call the vocal cords, okay? So when we talk about vocal cords, right, we talk about false versus true vocal cords. So true vocal cords are the vocal cords that actually produce sound, right? False vocal cords, the technical term for false vocal cords are vestibular folds. And I will make sure on an exam that vestibular folds is used if the term false vocal cords are used. So what happened, and I kind of like this cartoon drawing here because you can see that the vocal cords, the true vocal cords, that they have both length and thickness associated with them. And that length and that thickness plays a really important role when we talk about aspects of sound like pitch and tone and things of that nature. So, but anyway, going back to this slide. So here are the true vocal cords right here. Here are the false, or the false vocal cords, or the vestibular folds, right? Here you can see the corniculate cartilage and the cuneiform cartilage. And then here you can see the epiglottis. So this is just to kind of give you, that's what this vantage point is. And what happens when we produce sound is that we force air through these cords, and then these cords, which you can also see here as strings, will vibrate. And they will vibrate at a particular frequency, and that frequency is the sound that we produce, right? So there, when we talk about sound, there are different characteristics or aspects of sound, right? We can talk about it for any particular sound, and for any particular, I guess, individual's voice, there is a various range, right? So basically range being, range being how high or low your voice can be, right? There's a pitch, and pitch is kind of, I think of range as being tone, and pitch as being, so range being how high or low you can make your voice, right? And the tone of your voice. Pitch is the inherent high or lowness, right? So everybody's voice has a particular pitch. I mean, like I said, the concepts of pitch and range are related. And then loudness, of course, we all have the ability to talk quietly or to make our voices louder. So both range and pitch. So range is determined, and like I said, it's the length and the width of the vocal cords are what determine the range and the pitch. So, and just like when we were talking about the laryngeal prominence, the vocal cords also, the true vocal cords also have quite a few receptors for testosterone on them. So in the presence of testosterone, the vocal cords will grow longer and grow wider, right? And this is why for genetic males, as they go through puberty, they're, a phenomenon associated with that is having their voices crack. And that's because as they go through puberty and they become exposed to higher and higher levels of testosterone, those vocal cords will both lengthen and widen. And so the pitch of their voice drops because the frequency of the vibration is lower, and the range also becomes more baritone. So the range of a voice is determined again on the length and thickness of the vocal cords. And as I said, genetic males have longer and thicker folds. And then the pitch is determined by the frequency with which the cords vibrate. And so the pitch, if you've got longer and thicker cords, your cords will, by their very nature, tend to vibrate at a lower frequency than if you're somebody who has narrower and shorter vocal cords. So genetic males also tend to have lower frequency. Their pitch tends to be lower. And then loudness is determined by how much air we force through our vocal cords. So if we force a lot of air, our voices tend to be loud. Not a lot of air, our voices tend to be quieter. Okay, and then laryngitis. So laryngitis, itis, of course, is used to describe inflammation of. So laryngitis is an inflammation of the larynx. Can be caused by overuse. So inflammation just due to overuse, the presence of nodules can cause laryngitis. And those nodules can develop as a result of inflammation.
Hey Corey, I think you might have cut out again, or at least for audio.
Whisper. Did I lose?
Yeah, you just came back.
Yeah, you got cut off.
You cut off when you just started to talk about how you can get laryngitis.
Oh, okay. Forget it. Let's just call it a day today. I will. I am so sorry. What I might do is just re-record one video with going up till where we ended today.